everyone, this is a demonstration of the cardiovascular exam. Before we begin, we need to make sure that our patient is positioned properly, and that means they are lying supine on the bench. You may offer them a pullover underneath the head if that's more comfortable for them. Before we begin the exam, let's review the anatomy. Within the chest region, we have two clavicles, and the sternum sits right between those two clavicles. The first rib that is palpable underneath the clavicles is the second rib, and that's followed by the second intercostal space. So on the right hand side, in the second intercostal space, near the sternum is the aortic point. On the left hand side, in the second intercostal space, near the sternum is the pulmonic point. Counting down from there, we will get to the third and the fourth intercostal space near the sternum, and those two are the tricuspid points. Carrying on down to the fifth intercostal space, and as you reach the point that's just medial to the mid-clavicular line, that is the mitral point. That is also known as the apex, or the point of maximum impulse, the PMI. Let's begin our inspection. First thing to look for is cyanosis, and the best place to observe for that is the tip of the nose, the lips, the earlobes, and the fingertips. While we're looking at the fingertips, we will look for evidence of finger clubbing. So, observe the shapes of the nails first, and then ask the patient to place the nail beds against each other, like so, and that includes the thumbs. When they have done that, observe how the fingertips are. If the tips are pointing away from each other, this could be an indication of finger clubbing. Now move back onto the neck. We're looking for any evidence of engorged neck vein. And this is followed by observation of the chest, looking for any chest deformities such as barrel chest, pectus excavatum, and pectus carinatum. I'm also looking for scars, lumps, and pacemakers in the precordial region. And then we move on to the feet, where we look for edema. Now the inspection focuses on the precordial region. We're going to look for general movement that's associated with the beating heart. And then, using a pen light, we're going to apply a light source tangentially onto the mitral point, which is also the PMI, and we're looking for that beat. That should be the size of a quarter. Now, this is not always visible on patients, especially if they have a lot of soft tissue overlaying the area. Next, we move on to palpation. I'm going to perform general palpation first with my whole hand. Be sure to cover the entire precordial region, especially those auscultation points that we have just located. As I'm palpating in the area, I can feel the heartbeats, but I'm also looking for thrills or exaggerated ventricular impulses that are not supposed to be present. Next, I move on to palpation of the arterial pulses. On a real patient, we generally have to perform the pulse palpation bilaterally. However, for the purpose of this examination, you only need to demonstrate the pulses on one side and verbalize that you will perform this bilaterally. I'm going to start by locating the radial pulse, which is on the lateral wrist. I'm going to make sure I'm palpating with my index and third finger, definitely not the thumb. As I'm counting the pulses over a period of 15 seconds, I'm going to multiply that number by 4 to get the number of beats per minute. In a normal person, that should be within the range of 60 to 100 beats per minute. You only need to do the counting over 15 seconds for the radial pulse. For the remaining pulses, you merely need to locate the pulses. The next one to look for is the brachial pulse. So we locate that by going to the biceps tendon, and it sits just medial to the biceps tendon and is superior to the elbow crease. Next, we move on to the carotid arteries. The carotid pulse is located just anterior to the SCM. Be sure not to palpate this bilaterally. After the palpation of the carotid pulse, I will need to auscultate the pulse. This is particularly important if you detected a thrill or if you were looking after a middle to late-aged patient. I'm going to use the bell to auscultate over the carotid artery, listening for any bruit. Next, I'm going to locate the subclavian pulse. The subclavian pulse is located on the medial third of the clavicle, superior to that, and with this one, you'll need to dig in behind that clavicle to feel for the pulse. Now we move on to pulses for the lower extremity. We start with the femoral pulse. We're going to ask our patient to place the heel of their hand right at the level of the belly button with the fingers pointing down. Now the fingers should be located over the pubic symphysis. We're going to ask our patient to keep their hand there to protect the sensitive parts. We'll then locate the ASIS, and somewhere between the ASIS and the pubic symphysis is our femoral pulse. Remember, this is the only one we do not perform skin on skin. So I'm going to palpate along that inguinal region, feeling for that pulse. Next, we move on to the popliteal fossa, where the popliteal pulses. So we ask the patient to bend their knee, and we're going to wrap our hands around the knee like so, with our fingers pushing in to the popliteal fossa. In some patients, it may be challenging to locate the femoral pulse and the popliteal pulse. And that is okay, because as long as you can find the pulses more in a more peripheral region, that means the blood flow is going down to the whole extremity. Now we move on to the feet. We're going to locate the posterior tibial pulse, which is behind the medial malleolus. And lastly, the dorsalis pedis. With this one here, we're going to ask the patient to extend their big toe to show that tendon nicely. And then the palpation of that pulse should just be lateral to that. Relax now. And that completes our pulse palpation. We now move on to auscultation. Looking at our stethoscope. Remember, we have two parts to the stethoscope, the diaphragm and the bell. The diaphragm is best for listening to normal heart sounds, whereas the bell is best for listening to low frequency sounds such as murmurs. So we're going to start off by engaging the diaphragm. We're going to listen with the diaphragm over all the auscultation points that we have located previously. So starting with the mitral, that is in the fifth intercostal space, just medial to the mid-clavicular line. Moving on to the tricuspid, That's in the third and fourth intercostal spaces on the left, next to the sternum. And then moving on to the pulmonic point, and that's in the second intercostal space next to the sternum on the left. And lastly, on the aortic point, that is the second intercostal space next to the sternum on the right. Next, we're going to engage our bowel. Now we're going to listen with the bowel at the mitral point, looking for any potential murmurs, and then at the tricuspid points. Once again, listening for any potential murmurs. The next step in our auscultation is to accentuate the mitral murmurs if there were any. To do so, we will place the bell of the stethoscope over the mitral point and then asking our patient to turn on their left side. This will bring the heart closer to the chest wall and hence accentuate any mitral murmurs if they were present. And back to the normal position. The last step in our auscultation is accentuation of the tricuspid murmur. So to do this, we need to go back to the diaphragm. We're going to place the diaphragm over the tricuspid point. We're then going to ask the patient to sit up, lean forward, breathe out, and hold their breath in exhalation. And you may lie back down. As I'm auscultating for this examination, I am looking for S1 and S2 sounds, which are normal heart sounds. As I identify them, I need to look at their character and regularity. I'm also looking for any potential presence of abnormal heart sounds, such as S3, S4, and murmurs. The blood pressure measurement is also part of the cardiovascular exam. But because I've already done that in our lab last time and I don't have a cuff at home, we won't be including that in this video. And that's a wrap.